Thanks everybody for staying, and I'm going to thank you ahead of time for staying awake right after lunch. I know it's hard. So, I had a couple of topics I wanted to just kind of bring up to the group. It's a small group, so we can get into some discussion. So I'll try to respect time. I call this MVP, plug use in AVMs, but it's really an opening to a different discussion about basically management of steel and AVMs from with all the tools that we have. These are disclosures, which I don't think are really relevant to this, especially since, well, Medtronic, frankly, Medtronic is the company that makes the plug, so I have to throw that out there. But I'm also, there's no question I'm discussing something that's off-label. So when we start, this is a patient of mine who I'm still kind of caring for. When she was 2, she started having myoclonic movements that no one ever scanned her for, and everyone ever had an idea. And then when she was 16, she had a fall, and she was diagnosed with a inoperable AVM. And she came back into our clinic around 2007. We kind of had the same opinion. She hadn't had any episodes. And then over a period of about 2007 to last summer, she had progressive right-sided hemiparesis. She developed an aphasia. She's very well supported by her family, but lives in an assisted living facility. Between June of 2018 and April of 2019, she had 5 separate hemorrhages that were all intraventricular. One could argue some kind of in the posterior aspect of the AVM. But typically around intraventricular. She never developed hydrocephalus. She was able to get through each one, go back to her living facility. There was a suggestion of a distal choroidal aneurysm, and we'll get into that later. But we really got to the point where I'm dealing now with the large AVM that is changing somehow. Why does she keep developing the hemorrhages? And she's continuing to progress. So in the context here, we're talking about large. I hesitate every time I use a special Martin grade because we know that's a surgical grade. That's not a treatment grade, but that's our language. We typically would still call it 2 to 2.5% bleeding risk. Intranasal aneurysms are a concern. We saw one here. But the cognitive and neurological changes also, and also her progression, you start kind of coming up with the topic of steel. Steel, as we know, is related to the size of the AVM, the peripheral drainage of the AVM. We talked about veins yesterday, and so there's a real correlation with the venous drainage and how many larger or smaller peripheral veins are draining the AVM and how much steel we might see. So in this lady, we had multiple hemorrhages, we had a progressive steel, and we really had to kind of say, what are we going to do now? We've been watching you for so long. So there was a lot of discussion with her family. Obviously, with her aphasia, she was very interactive but couldn't express as much. But we came up with basically the goal we had was to give it, if there was a way to address any kind of steel or the high flow of the AVM had taken, and again, flow is another topic of the last couple of days, and potentially treat that choroidal aneurysm with a goal of keeping her in an assisted living facility, making sure that she didn't get to the point where she was going to have to go to a nursing home. The discussion that we had was decreasing the flow through the fistula to kind of limit the progression of these deficits, which had really, really ramped up over the past year. But also, as we talked about yesterday with the cerebellar lesions, I found with cerebellar lesions, taking down portions of the cerebellar lesions, we understand a lot more what's going on, and frequently it changes a lot how the lesion behaves. So again, I've mentioned this a bit, but really going into decreasing the flow, and this progression was kind of the goal of the patient. This was actually her in 2006, the kind of upper portion of it, and this is kind of the upper portion in 2012. So this is an area that I just kind of chose where you can see differences in just the encephalomalacia around the AVM, okay? So a lot of the discussions that we've had about the AVM so far have been, the steel and the collaterals around. I typically tend to believe that this is the AVM, and this is basically the sump from the AVM, right, where everything's coming into the AVM. But those aren't AVM vessels, and if we're targeting those, we're not doing anything for the AVM. We may be doing something for the steel. So in going into her procedure, the plan was to kind of take down some of the fistulous components of the AVM. In hopes that I could get a better idea, was this truly a choroidal aneurysm, or at least minimize that progression. So couple of, obviously access is much, much better from the standpoint, this won't go forward. Okay, so access is much, much better from our standpoint in terms of getting larger devices into the AVM. And I've had a few now 4 AVMs where I've kind of been working from a steel standpoint to kind of decrease the fissureless components. And as we all know, even the glues that or the onyx that I typically use, once you put it in a large fistula, it's just going to fly through the system. It really doesn't stop as well. So coils become an issue from an artifact standpoint and following the lesion. So I was trying to figure out what's a better way to quickly bring down the AVM from a fistulous standpoint. And these microvascular plugs, which are really more of a peripheral plug, and I don't know how many have seen them, but I've been using them for vessel sacrifice. And so I said, what if we started using these for AVMs? Distal access catheters really got me well into the AVM. This is kind of a pre and a post, and I've got some other images to show there. But over 3 different sessions, and we'll go into that, I was able to take down the AVM, the fistulous components of the AVM, a lot of the flow, with less than 2,500 milligray. So you're really taking a Cat 6 catheter out there, an 027 catheter into the larger vessel, take it down. And then, and we'll get into some of the concepts there. But this is our first DSA. This is kind of where we were at the beginning, and this is where we were towards the end. That's the first. I'm sorry. That's just the first look at the lesion itself. These are control images. This is getting the catheter into the various more fistulous components of the AVM. And what you start to see after placing the MVPs, they don't typically just shut the AVM down. They'll slow flow down, and they'll thrombose behind it. So it's a little bit slower process of taking that down. You start to see the kind of stasis that we would see with some of the flow diverters. So if you can see, I can't zoom in on that, but this is kind of the front and the back of the plug. That's the front and the back of another plug, and you're starting to see that stasis and the contrast there. But you can pretty much go, this is after 4 of the plugs where we've gone from this to that, and we've gone from this, down to that. So we're starting to see a little bit of a difference in the AVM. And then after the 3rd one, if we go all the way from our initial study here, we're starting to see a difference in the flow. And that's a typo. There weren't 7 in there. There were 5 in there. But during this time, over about a 4-month period of time, I had a lady that went from her hemiparesis, where she was using a device to get around in an AFO, to the point where she stopped using her device, and she was actually able to stay home in her assisted living facility and walk. So she can now walk without a device. She's now using her arm. Her aphasia, I didn't have much hope for that getting much better. It had been going on for so long. But she definitely reversed some of her deficit and got to the point where she was, I think, just taking the flow down made a difference. I still have to get it. I have functional MRIs that I need to compare, because I'd like to see how that changed as well. But we really went from, and then we got to the point where I actually I was able to see the choroidal aneurysm. So this is the aneurysm off the distal anterior choroidal, and we were able to get into that, and we glued that. And I think that was the reason for her bleed. I don't think the bleed was had anything to do with the steel. But I thought we got to our goal here in a kind of a low radiation way. And then interestingly, what she got to was a very significant decrease in the AVM peripherally, but a lot of lenticular striates going out into this and feeding the rest of her AVM. And this is where I get a little controversial. But if we got to a point where all she has is lenticular striates, which are feeding the AVM, would you ever think about flow diverting that MCA? Right? Because now she doesn't have any, how much is she using lenticular striates if they're all going to AVM? And half the reason when we put flow diverters in there, we're getting rid of, if flow's needed, right? But I didn't do that. It actually crossed a couple of our minds, because that's pretty much all she had left at the end of her, at the end of the embolization, was a lot of lenticular striate feeding. There's your choroidal aneurysm. So I've had again 4 separate AVMs where we've been able to see patients who have progressive steel, and I've watched them over about 10 years, to the point where they've become less functional, and we've gotten to that point. Is it worth considering treating steel with some of our embolization techniques. I think the way to do that is really decreasing flow through the fistula to limit progression. We can definitely see those high-risk lesions, see intranatal aneurysms that we wouldn't be able to see because of all the fistulous components. And I think it's really a little more straightforward now with the devices that we have for stroke. The MVPs are helpful. I think the cost on the MVP in the U.S. is somewhere about $1,500 to $2,000. So as opposed to how much radiation she got versus the number of coils it would take to take down those fistulae, I think it's probably cost effective. Where I haven't gotten into yet is really looking at taking those patients using NOVA or ANOVA, as the statistician would say, and really quantifying how much we took that flow down by going through. I think that would be kind of our next step. I talked in a prior meeting in Zurich, we talked about using some of the arterial spin labeling methods to also look at quantifying the flow going through the AVM. So quantifying how much we're taking down, I think would be kind of a next step for me. This is where she was in 14. This is where she was in 19. So she's been pretty stable. Interestingly, you can see the flow voids a lot more on the T2, but on the contrast images, the contrast is a lot more. It's not as dense on the newer images as it was on the older ones. So, and I really began to convince myself that it was actually resectable, but again, not with her age and with her deficits. So. This is just a little bit about these plugs and how I've been using them. I've not had any issues with bleeding. I've not had any issues with deploying the plugs. They all go pretty well. We just have to be careful knowing that it just doesn't shut it down right away. It does take, in effect, the patient will clot them off slowly, but we'll see the effect every time. And you have to kind of anticipate here because the larger ones for a larger vessel, typically we're not going to see that in an AVM, but these come into play every time, and that's an 027 catheter that you have to get out there. So, but typically with a CAT6 in the MCA, we can go 3 different times, and it's actually pretty quick. So, I've had one patient that I guess the counter argument to this would be in patients who you're embolizing for surgery, right, or you're embolizing to take down blood flow. I did this, I've used a couple in patients who went to surgery, and that was helpful because it did decrease the amount of glue I'm putting in an AVM. And when we're operating on the AVMs with glue, it tends to be hard, and it tends to be a little hard Onyx, to get around. And so if I'm very strategic about how much nidus I'll get into versus just taking down blood flow problems, I'll use the plugs for that, and basically you can see the plug, you can cut right in front of the plug and you're done. That really decreases the amount of time that we're in, so I've used it for that. And then again, for vessel sacrifices and things for aneurysms, I use it as well. So there's benefits, but also I think the disadvantage is you're really not getting the nidus penetration, so you have to kind of think about that. Even though you're clotting it, it's not getting into the nidus. So. So I think, we could talk all day about steel. We've had some radiosurgical aspects of steel that we're working with in addition to just the embolization that we can do. But I think the plugs are helpful. And I think in this lady and another of the 2 ladies that I've treated, I've watched over time, we've really seen a stop in their progression, if not some reversal. So I will finish there and see if anybody has any comments on that. So thank you. You got.
Yeah, thank you, Babu. This is a very nice concept idea. Have you tried it, or maybe considered to combine it also for AVMs that you would like to cure, like so have the plug, or otherwise maybe a balloon or whatever, or coils. You just put a plug a little bit proximal and then have a second catheter, and then do a nidus injection, especially for those things that are fistulas or that are high flow that you are concerned about, having the vein too fast filled with your onyx or squid or whatsoever you think that's feasible?
Yeah, it's so coiled behind it, because initially I was a little concerned it would just fly, right, if you put it out, just like we were with coils. But interestingly, they wedge pretty good. So if you plan the size, and that's why that 5 to 7 comes into play. If you use a 5 to 7 plug and then coil behind it, that actually works pretty well. And you can do the larger coils through. If you can get an 027 catheter out there, you can coil pretty effectively in a larger fistulous vessel, and it takes down the number of coils you're going to use. So I have used it for that. So, you know, I have Onyx behind for a sac, but really I don't think that was that cost effective, right? You know, because the plug takes it down so well, the coils really just, in my mind, make me feel better about it potentially dislodging. And so I have used Onyx. I wouldn't do that again. I would just coil behind it. It's cheaper, and it's just as effective. So.
Did you listen to Jacques' talk yesterday? Because he mentioned that he had some AVMs that he didn't understand the anatomy, like this, lot of vessels, and then he just pushed glue just to slow down some direct fistulas. And then in one case, he got a wonderful result 3 years later.
Well,
so
yeah, that's why I mentioned those cerebellar. And I told because he asked everybody, he said, "Would you be surprised?" And I wanted to say no, because there's something about, and I don't know. I commented on this yesterday. Something about the cerebellar drainage and that really kind of reet of veins you see around the cerebellar AVMs that you don't see as much on the supratentorial ones. I don't know what that is, and I don't know why. I've seen in 3 different instances pretty good embolization that just progresses to gone. Right, they're not gone when I'm done, and I've done all I can do. But then we either sat back and watched, or one person, there was a small nice that we radiated. But what does that peripheral venous drainage have to do? And the one he showed was exactly like the 3 that I've seen just go after good embolization. So I don't know the answer to that. If you have anything that.
So this look hopeless from the beginning, but now it looks better, and probably in a year or 2, if you can do a follow-up, probably it will be something.
It really, and I didn't get you all even the contrast pictures, it's really gone down to very little. So David had one, I think. Yeah.
It's the smallest artery diameter you can put the 5 through. Can you put it in 2 millimeter? Can you put it in?
You can get as low as, I mean, it'll open up. I was going to show you that image again, but so.
Catheter and also stiffness and all that.
Yeah, so you can, these 2 need to go. This is 021, so it'll open in that 1.5 to 3. Yeah, and then, but I've typically, because I'm leaning more towards the fistulous ones, I typically oversize. The trick is, if you undersize it, it's going to fly, because it's basically an umbrella, right? So you want it, but if you oversize it too much, then it won't open as well in the vessel. But that's why they give you that range. That 3 to 5 range is usually where I've used most of them. I haven't really needed to go as low as that, except for, I think there was a pica going to a big AVM in the posterior fossa that I went maybe at 1.5 to 3. So.
What do you pay for that?
So again, depending on the size, but it's somewhere between 15 and 2. So if each coil is 1,000, right? For us, coils are between 7 and 1,000, so 700 and 1,000. So that takes care of. That's all I need, really. I've gotten to the point where it's on a wire, and you basically just unscrew it, right? So if you think it's going to fly, you can tell. And early on, I had to worry about it flying, but I got to the point where I can wedge it pretty good. I'm not worried about flying into the AVM. So, and it's quick. So radiographically, it's not, and that's what you have to get used to. Radiographically, you're going to see it kind of pull behind, but give it 10 minutes and it's gone. So, yeah. So.
Maybe I misunderstood, but in your conclusion, one of your conclusions was when you don't want to wear nidus penetration. Well,
I don't know why I did that. So let's. Sorry.
You did.
Yeah. I did it on purpose, right? Yeah. So.
On purpose.
Yeah.
Okay, so the treatment where nidus penetration is not desired. When do you have this situation?
So that was
because we want always that our problem is when the onyx or the glue doesn't penetrate in the nidus, but it's exactly what we want is that goes in the nidus.
You want that because you're not operating on it, right? If I'm the surgeon and I'm operating on it, I think it gets very hard, and in a lesion where it's kind of superficial, but then you have to go deep. It's hard, it's not compressible, especially if you're using onyx. And so
Yeah, we
what
are
I'm,
using Onyx.
yeah, so if you're using Onyx, it's not very compressible. And if you've taken the vessel and you're not, and you can go to that plug and amputate that and decrease that flow by putting the clip on it, then to me, that's preferable than having to try to press down the AVM.
So this is pre-surgical?
For pre-surgery,
Ah,
yeah.
okay.
Yeah,
And
correct.
the other thing is, do you think it's really steel? Does it exist, the steel in the AVM, or does exist the hyperpressure from venous system? Because the steel is something that we don't understand very well.
I agree. That's why I start with that picture of, kind of the MCA region pulling everything across the ACA circulation. And this lady is a perfect example. Their examination, her examination was aphasia in a left-sided hemisphere AVM, right? Fit. Arm was her next thing. So her hand was weak, okay? What really made her incapable of almost taking care of herself was her leg went, right? If we're going from the AVM, we're going, aphasia to hand to leg, that's a good argument for now I'm pulling things across that watershed area, and I'm losing my leg ultimately because the AVM is dumping and dumping and dumping through that low flow state. So I agree with you. I think there's a lot we don't know about steel, but when you really follow the exam and watch these patients dwindle, and all the patients I've treated have been, I've been watching them for upwards of 10 to 11 years, right? Until we get to the point where we can't, there's something we should do, but I'm still trying to figure out exactly what we should do and how. But so short answer, yeah, I believe steel, but with our theme of venous management, I don't think we can avoid a venous component to this and the pressure in the veins, right? But remember, an AVM is a low flow state, right? It's a low flow, low pressure state. So that's why I lean more towards the stealing part, right? So.
Okay, thank you, Babu.
Mhm.
I think it's for me it's totally contraindication, because this is the same of the presurgical clipping before with a facial AVM, a proximal clipping or ligature.
Mhm.
Okay, I think this don't stop the pathology is the nidus or the shunt.
Mhm.
You only open the more anastomosis, and in your presentation you are sometimes it's good before surgery. It's incredible. It's impossible to operate this AVM after you put this proximal. No, I think maybe it's good to control high flow fistula, but in general is a proximal occlusion, and this in the future is more dangerous because the AVM growth with around the collateral circulation. With this device, with another device.
Sure. Does an AVM really grow? Right? I think they change, but they don't grow. Right? Yeah.
I deploy this, and you're going to surgery after now?
Yeah. Sure. I just said I did. Yeah. So because you
operate this?
Did I operate this?
Yes.
No, but remember that was
No.
not the plan, right? And but there are like I said, there are some that I have operated on going this way. Right now, did I onyx part and then plug other parts? Yeah. Okay, because I want to take down flow within the nidus, right? But it's again, from a surgery standpoint, I'm thinking about the pain I'm going through in the OR, trying to, compress this thing, get around it, pull on the healthy brain because I can't pull this rigid mass, right? Onyx is more rigid than glue, right? Than NBCA, yeah. And so so in my mind, I have to think about it that way because that's why I like playing with the whole thing, right? Because I'm helping myself. Or when I talk to my colleagues in radiology, they know, look, this part we need, this part we don't. This is what we're gonna have to take down. But yeah, I just could not find my video to show you intraoperatively what this looks like when you're in there. But you clip it, it's gone. You know where it is because you can go right to where this metal plug is, which is sitting right in the vessel. Clip, we're done. So it's like I said, I brought that up on purpose because I know it's interesting. But
How big were these vessels?
so that's a 5 to 7 plug, right? So they're usually a 5 to 7, I'll put a 6. I've never had to go 7 to 9, right?
Too big for a scepter?
Too big for a scepter, no. But you mean scepter and then onyx it, or
Yeah, so
yeah.
again, we've done this even before scepter with using other balloons. You just, again, you arrest flow with that, put a coil or two.
Right.
And then just onyx that fistula there.
Yeah. For me, I guess I was thinking more about from a radiation standpoint, because this literally is boom, 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 and I'm done. I did 3 sessions in this lady for 2,500 milligray, right, as opposed to sitting on the pedal and going onyx, and that's another option, no question about it. Yeah.
So, Mike, again, in the environment that we live, again, God forbid you have a complication with this.
Yeah.
This is totally off-label, and you're using a tool, so that's my only.
Yeah.
I think it's what would be interesting is using this in a reverse way with all this exercise that you see from, for example, René does for reverse pressure cooker on the venous side. You have a plug that is big enough.
Yeah.
You can just put that behind that and use the plug to hold your embolic material in it.
So I've actually punctured one and embolized beyond it.
Yeah.
Ricardo, you are neurosurgeon also, no?
Yeah.
You are neurosurgeon. Also, no. You are this AVM. What is the difference when you put one device in the 6 vessel on your ligature, this the carotid, or you are comfortable to go into the angio room and over the surgical room?
No, I understand what's crazy. No, I disagree, Luis. I think what he's doing is he's treating a fistulous component
that's
of an
agreed.
AVM.
Yes.
That's,
Yeah. You just leave the surgery to us, okay? Yeah.
And Luis, for this we have data. SEPI has showed this beautifully. You can measure the flow with this node.
Enormous AVM.
I know, but you can measure the flow on that vein and see reduction on the flow on the vein. No, it's data. It's not blah blah blah.
Yeah.
No.
It's not. It's
You are
data.
neurosurgeon. You remove this AVM after
One has
this
to
device.
say yes to him, otherwise he will keep on.
Actually, I think it's reasonable that use this kind of plug, especially in the pediatric patients. Normally, they have AVF, so use this one is very It's very useful. Yeah,
especially,
maybe
again,
only one plug is enough,
With
because
radiation in the
otherwise,
kids, too.
the fistula when the artery close to the fistula, it's getting larger and larger. So normally you have to use balloon assist coiling to treat this one, and sometimes it's very, very difficult. So use this one is much easier, I think. Yeah, I saw Professor Giuseppe Lanzino in Mayo Clinic. He used this one. Yeah.
He said he didn't, because we're
Yeah.
actually pulling we were going to pull some cases together. So, but now it's.